Okay, today we're going to talk about DKA and HHS. We're in the concept of metabolism. DKA is caused by an absence or markedly inadequate amount of insulin. This deficiency results in disorders of metabolism of carbs, proteins, and fats. DKA stands for diabetic ketoacidosis. HHS is a disorder resulting from relative insulin deficiency initiated by illness that raises the demand for insulin. HHS stands for hyperglycemic hyperosmolar state or syndrome. So let's compare DKA versus HHS. So DKA is usually with type 1 diabetics. However, it can occur in type 2, but it's more common in type 1. It really just depends on the degree of insulin resistance. With DKA, the onset is usually quick, less than 24 hours. Their blood sugar is greater than 250. It's usually 300 to 800. It will depend on their degree of dehydration. When we talk about blood sugar levels with DKA, the severity of DKA is not directly related to the glucose level. With DKA, their pH will be less than 7.3 because they're acidotic. Their bicarb will be low, usually less than 15. They're in a metabolic acidosis state. They will have urine and serum ketones, hence the ketone part of DKA. BUN and creatinine levels are usually elevated. Their serum osmolality is 300 to 350, and the mortality rate is less with DKA when compared to HHS. Signs and symptoms of DKA, you'll see your client has polyuria, so an increase in urination to rid the excess glucose, but also when they're voiding, what else are they excreting? They're excreting their electrolytes like sodium and potassium. So this will lead to a dehydration and electrolyte loss. They will also have polydipsia. Since they're urinating a lot, they get thirsty because they're dehydrated. They may complain of blurred vision, weakness, fatigue, a headache. They may have orthostatic hypotension related to the dehydration, and again, related to the dehydration, a decreased blood pressure and increased heart rate. They may also complain of anorexia, nausea, vomiting, diarrhea, abdominal pain. Another markedly symptom of DKA is acetone or fruity breath. Their breath smells like fruit stripe gum. You may see Kussmaul's respirations, which is a rapid, deep respiration. It's not labored, but it's really rapid inhale and that long exhale. Because remember, they're acidotic, so they're trying to blow off that excess too to balance their pH. Usually their CO2 levels will be low, like 10 to 30. Mental status will vary. They can be anywhere from alert to comatose or even lethargic. Now let's look at HHS. HHS is a metabolic disorder, usually with type 2, that results from relative insulin deficiency. So we have a hyperosmolar and hyperglycemia predominate, but the ketosis is absent. So that's one thing that's different from DKA. So these clients are not in a state of ketosis because they produce some insulin, whereas DKA, usually type 1s, do not produce insulin. Persistent hyperglycemia causes osmotic diuresis, which is the loss of fluid and electrolytes. Hypernatremia and increased osmolality can occur. Remember, it's related to dehydration. HHS can occur in both type 1 and type 2, but it's more common in type 2. The onset is longer in duration, usually greater than 24 hours or over several days. They're going to have a higher blood sugar. usually greater than 600. They're not acidotic, so their pH will be normal and their bicarb levels will be normal. They will not have urine serum ketones. Their BUN and creatinine levels will be elevated. This time, their serum osmolality will be greater than 350 because they're very concentrated, because their degree of dehydration is a lot more when compared to DKA. And we have a higher mortality rate here. Signs and symptoms you might see, again, polyuria, trying to rid the excess glucose. Since they're peeing a lot and excreting a lot of their fluid, they may complain of polydipsia, so thirsty. They don't have those GI symptoms because they're not acidotic. However, you will see a lot more neurological changes. They may be confused, altered LOC, seizures. They may even have hemiparesis. So if you think back to stroke, we talked about hemiparesis. This is why we always do a blood sugar on stroke patients to rule out HHS. The reason they have these symptoms is due to the cerebral dehydration as a result of that hyperosmolality. They'll have hypotension. Their dehydration is more profound, so you'll see a poor skin turgor and dry mucous membranes. You will also see tachycardia. So with DKA, the three main clinical features are hyperglycemia, dehydration and electrolyte loss, and acidosis. The main causes of DKA, it could be related to a decreased or missed insulin dose, maybe not enough prescribed, or maybe the client didn't administer enough. Maybe they're trying to space out their doses because they can't afford the insulin. Maybe it's an error in drawing up the insulin, like with the visually impaired. Maybe it's the intentional skipping insulin doses, again, maybe related to the cost, but it also could be a young person not really coping with the disease and not wanting to treat their DKA. Could be equipment problems, like if they had an insulin pump, their tubing is kinked, or the syringe is not loaded correctly. Could be cause for illness or infection. Clients think that they're sick and they're not eating and or vomiting, so they don't need the insulin or take it at all. However, we know this is not the case. They actually need more insulin at this time. So make sure you look at the sick day rules in your MedSurg book, page around 1484, and it's chart 51-9. DKA can also be caused by undiagnosed or untreated diabetes. So let's talk about DKA and HHS, what happens. So without enough insulin, the amount of glucose entering the cells is markedly reduced. So these cells are starving. They don't have the glucose for energy. So the liver says, hey, I know what to do. I can start kicking out glucose. This is called gluconeogenesis. So the liver releases the glucose. So then we have a rise in our serum glucose levels, leading to hyperglycemia. So in an attempt to compensate for this hyperglycemia, the kidneys excrete glucose, so glucosuria. We also excrete the electrolytes, sodium and potassium. These clients may lose up to 6.5 liters of fluid. Then the client becomes dehydrated. Remember, we need insulin to bring glucose into the cells so that we can use it for energy. So for whatever reason, these patients aren't getting the insulin they need. For whatever reason, they're not taking it, or maybe not increasing their dose. But ultimately, the dehydration can lead to renal failure. And if it's so severe enough, it might even lead to hypovolemic shock, which could cause cardiovascular collapse or cause them to cardiac arrest. So let's add on another little leg here. So this leg is just related to DKA. So another effect of insulin deficiency or deficit could be the breakdown of fat, which is called lipolysis, into free fatty acids and glycerol. So think about that ketogenic diet. It's essentially what people are doing. They're decreasing their carb intake so that their body is burning fat. Well, a byproduct of fat metabolism is ketones. So the body is still unable to use glucose for energy, and due to the lack of insulin to pull it into the cells, so the body thinks it's starving and senses, hey, we need more glucose. So the body begins to break down fat into free fatty acids. The free fatty acids are then broken down into ketone bodies by the liver. Ketones are very acidic in nature, and this is what leads to our metabolic acidosis. This only happens with DKA. So if we put it all together, this is what DKA looks like. You have two legs, two things happening at once. Now remember, the lipolysis only happens with DKA and not HHS. So treatment, how are we going to treat it? Well, let's see, it's related to insulin deficiency, so we're going to give them some insulin. So we have to treat the hyperglycemia, correct the dehydration, fix the electrolyte loss, and reverse the acidosis. So to treat the hyperglycemia, let's give insulin. What route are we going to give it? Well, we need it quick, so we're going to give it IV. And the only kind of insulin that we give IV is regular. You usually titrate it per specific facility protocol, but just know that you do titrate it based on a protocol. You don't have to memorize the protocol because there's all kinds of different ones out there. Just know to follow your protocol. Meanwhile, we're going to monitor the blood glucoses every hour and titrate based on that current blood sugar. We always use capillary blood, like with a finger stick, and not venous glucose levels, like on a chemistry. These glucose levels will be lower. Even when blood glucose is stable, times 2 checks, so it has to be stable for 2 hours, we can start to transition the patient to sub-Q insulin. Usually they'll have a long-acting insulin and sliding scale insulin. For rehydration, we're going to give them boluses. So they might receive as much as 6 to 10 liters of IV fluids to replace what was lost with that nausea, vomiting, diarrhea, and polyuria. However, while we're giving these fluids, you might also see their electrolytes go down or maybe back into normal level. Initially, we'll bolus with about half or 1 liter an hour for about 2 to 3 hours. So that's 2 to 3 liters in that first 3 hours. If they have hypertension or heart disease, you may see half normal saline ordered. However, after the first few hours, so after those boluses, then they get maintenance fluids. And it's usually half saline, and it's 200 to 500 milliliters per hour for several hours. So kind of fast. Once our blood sugar reaches around 250 to 300, we're going to change that half normal saline to fluids containing dextrose, like D5.5 normal saline. We do this to prevent a too fast of a drop in the blood sugar. If we kept them on that half normal saline and on the insulin drip, their blood sugar will drop, and it's very fast. We don't want it to drop fast because then you can have really irreversible neurological changes. We also want to restore those electrolytes. The main one we're concerned about is potassium. So initially, when the patient presents, their potassium may be low, normal, or high. However, as we initiate treatment, i.e. the insulin drip, you'll see the potassium will be pushed back into the cell, dropping the potassium. Also, as we're giving fluids and boluses, you may see the potassium washed out or diluted a little bit. So with the potassium replacement, the timeliness of it is vital. So we usually start potassium replacement when the potassium levels are still normal, not elevated though, and do not wait until they're already low. Once they're low, it's almost too late. You're going to play catch up for a while. So as long as potassium's not high, and it's within normal range or low, we can start to give potassium replacement. You might see upwards of 40 milliequivalents per hour for several hours. We want to monitor our EKG. So we're given potassium, so you want to watch for hyperkalemia. What would you see? Peaked tinted T waves? If their potassium's low, you might even see flattened T waves. We're probably going to do some serial labs, maybe every 2 to 4 hours chemistries. Look at the potassium and the ion gap. So with DKA, we have to be mindful and reverse the acidosis. So remember those ketone bodies? They're very acidotic. So they're causing an acidosis, metabolic acidosis. So usually when we give insulin, it'll help prevent the formation of these ketones. With the acidosis, we do not want to give bicarb. Bicarb will decrease the potassium even further and could be fatal to these patients. As always, we have hyperglycemia, but we're treating it. We could have hypoglycemia. So with hypoglycemia, the definition is a blood sugar less than 70. It can occur with too much insulin, maybe not enough PO intake, or excessive physical activity. When the blood sugar drops, your sympathetic nervous system is stimulated. A surge of epinephrine and norepinephrine are released. This will cause an increased heart rate, tremor, sweating, palpitations, nervousness, and hunger. With moderate hypoglycemia, this will cause our brain cells to be deprived of glucose, and you'll see an altered LOC. Maybe an inability to concentrate, a headache, lightheadedness, confusion, memory impairment, slurred speech, incoordination, numb lips and tongue, emotional changes, or irrational behavior and combativeness. With severe hypoglycemia, the client will lack the ability to treat their hypoglycemia and require help from someone else. This could progress to seizures, a stupor, or loss of consciousness. We always double check low values on the same ChemStick machine, and if it still says low, then we usually do a lab stick. So how do we treat hypoglycemia? Let's give 15 grams of fast-acting carbs. That could be 8 ounces of milk, 1 slice of bread, 3 graham cracker squares with peanut butter, or 6 saltines. If we give drinks like juice or soda, do not add sugar. This can cause hyperglycemia. We can also give glucose gel. At a lot of the facilities, they have the gel or the glucose drink that you can give your patients. If they can't take PO, we could give IV dextrose, which is 50% dextrose. You can give half an amp to a full amp, depending on what the glucose is. Before you administer it IV, make sure your IV is patent. The D50 can be very irritating to the veins if your IV is not patent. If they can't take PO and they don't have an IV, we can do glucagon IM or subcut. It's 1 milligram. Glucagon is a hormone produced by the pancreas that causes the liver to break down stores into glucose. It has to be reconstituted prior to administration. So usually you'll have a vial of sterile water and the powder, and you have to mix them. After administration, it may take up to 20 minutes for the client to regain consciousness. The onset is 8 to 10 minutes, and it lasts 12 to 27 minutes. So expect your sugar to drop again after 15 to 30 minutes. It's prescription only. Family and friends, as well as the patient, should be educated on how to use it, because the patient may not be able to, so caregivers need to be involved. We also need to teach the client signs and symptoms of hypoglycemia. So nursing care related to DKA and HHS. We want to assess our lung and heart sounds. We're probably going to do frequent vital signs like every 15 minutes. Monitor for hypo or hyperkalemia. Monitor the EKG for peaked tall T waves for hyperkalemia and flattened T waves for hypokalemia. We're going to check our blood sugar every hour. Titrate our IV insulin drip per protocol. Just a side note, when you're priming your tubing for your insulin drip, you must waste the first 50 mLs of fluid. So as you're priming it, the insulin will stick to the inside of the tubing. So usually that first 50 mLs is just saline and no insulin. So you might not see your blood sugar move at all. So make sure you waste that first 50 mLs when you're priming the tubing. Always monitor for hyper or hypoglycemia. We're going to monitor their urine output. Most of the times these patients will have Foley's. With HHS, since the degree of dehydration is so severe, you might see a central line placed and CVP monitoring in place. We're going to do frequent lab draws, like a CMP or BMP, which are chemistries, maybe some urine or serum ketones. We're going to do this probably every 4 hours. Assess their LOC and note changes. Be on the lookout for that cerebral edema related to those glucose shifts. Administer IV fluids and push PO fluid intake when they're alert enough and can take POs. We need to consult the diabetic educator and educate the client about the disease and its management. So diagnosis, nursing diagnosis, we have fluid volume deficit, electrolyte imbalance. Knowledge deficit could be related to meds, the disease, anxiety, or risk for unstable blood glucose. So remember, no matter the age of your client, we need to teach them about hyperglycemia, signs and symptoms, and how to treat it. Hypoglycemia, again, signs and symptoms and how to treat it. Their disease, the sick day rules, very important. And testing their urine for ketones. Those ketone sticks are over the counter. They can test their urine for ketones, and if they have ketones, they need to come in. All right, let's go over our scenarios. So the first patient presents to the ED with abdominal pain, nausea, and vomiting. She hasn't eaten in 3 days. She's alert and oriented, sinus tach with a rate of 116, and the blood pressure is stable. She is 33 years old and a type 1 diabetic. She does have a cough and a low-grade fever. Her initial labs are as follows. Her white blood cell count is 28, hemoglobin 12, hematocrit 36, sodium 130, potassium 2.2, BUN 50, creatinine 1.51, the anion gap is 36, her CO2 is less than 5, ketones noted in the urine, and the arterial blood gas shows a pH of 7.123, a CO2 of 18, and an O2 of 94. Based on this patient, what other labs would you recommend to the physician? We did ketones in the urine, so you might could do serum ketones, either one. And then she has a cough and a low-grade fever. What does that sound like? Possible pneumonia? We might need a chest x-ray and some blood cultures. Might even do a urine culture or a sputum culture. See what's causing all these symptoms. And what diagnosis do you expect? Is she in DKA or HHS? Look back at our scenario. She's a type 1 diabetic, and she has serum or urine ketones. So she would be a DKA. What treatment should this patient receive? We're going to do aggressive IV fluid resuscitation, Probably going to do some potassium replacement before starting the IV insulin drip. Why? Remember, insulin pulls that potassium into the cells. So if we give that insulin drip without correcting the potassium, her potassium could go so low and fatal, might even stop her heart or slow her heart. And then once her blood sugar is around 250 or 300, we're going to change those fluids to D5.5 or fluids containing dextrose, so her blood sugar doesn't drop so fast. All right, let's look at our other scenario. So a family member brought a patient to the ED complaining of increasing lethargy over the past 3 days. It is reported that the patient has been drinking a lot more fluids in the past week and seemed to urinate more frequently. The initial lab results show a blood sugar of 1,023. Her plasma osmolality is elevated. Sodium is 132. Potassium is 3.4. The ketones in the urine are negative. The white blood cell count is 16. BUN 25. Creatinine is 1.2. They admitted the patient to ICU for further workup and monitoring. Based on the history in these lab results, what diagnosis do you suspect? Do you think she's DKA or HHS? In this case, this patient's going to be HHS. How are we going to treat it? Again, aggressive IV fluid resuscitation, possible potassium replacement. It's on the low side and we expect it to go lower. However, we don't have to correct it as readily as we do the previous patient. Start them on an insulin drip, and then again, once their blood sugar gets around 250 to 300, convert it to IV fluids with dextrose.